Thank you for taking part in the second annual Are You OK campaign aimed at increasing awareness of the effects of high potassium can have on people with advanced chronic kidney disease, also known as CKD. My name is Gregory Oakes, and I'm here today representing V4 Pharma, where I'm president of North America. In the US and globally, we strive to help patients with kidney disease lead better, healthier lives and aim to become a leader in developing therapies to help treat complications of kidney disease, including high potassium. We're proud to continue our partnership with the American Association of Kidney Patients to raise awareness about potassium management among kidney and heart disease patients. At V4 Pharma, we're committed to empowering patients to become better educated about their disease. Today, May 1st, is National High Potassium Awareness Day. Along with the AAKP, we hope to engage and mobilize kidney patients, care partners, medical professional associations, and the larger kidney community around this condition. Thanks for doing your part on this important day for the community. Let's help get the word out about potassium management.
Hello, welcome to the latest Healthline webinar from the American Association of Kidney Patients. Are you okay? The importance of potassium management in kidney disease. Today's webinar is provided by an educational donation from V4 Pharma. My name is Erin Kale, and I am Director of Stakeholder Operations for AAKP. I oversee our patient education and grassroots engagement activities, including our Ambassador Initiative, which comprises highly motivated and engaged patients and caregivers around the country and the globe. These individuals have a direct connection to kidney disease and wish to raise awareness and provide support to others navigating the challenges of this chronic disease. AAKP's Healthline webinars fall under our Center for Patient Research and Education. We believe patient and caregiver education is an integral part of treatment and protection of patient lives, and we work to ensure that the patient has a central role in research and guidance that are designed to determine optimal approaches and strategies for providing healthcare services, assistance programs, and access to new products and services. In 2020, AAKP declared May 1st as a national movement to increase awareness about the devastating effects high potassium can have on individuals with advanced chronic kidney disease. In our inaugural year of the campaign, we reached over 2.5 million people. We appreciate you joining us today to celebrate the second year of National High Potassium Awareness Day. Potassium is found naturally in many foods, such as fruits and vegetables, and it is found in high concentrations in some processed foods, like tomato juice and fruit juice. It's an important mineral that plays a key role in controlling the function of nerves and muscles, particularly the heart. In a person without kidney disease, most of the extra potassium eaten in the diet, but when kidney function decreases to a certain level, the body cannot get rid of excess potassium. And if potassium levels become too high, an individual is diagnosed with hyperkalemia or high potassium, which is a serious and potentially life-threatening condition. Our objectives for National High Potassium Awareness Day are to educate kidney patients on the risk factors of high potassium or hyperkalemia, and on the signs and symptoms of hyperkalemia, discuss the connection between hyperkalemia and cardiac complications, explain the importance of knowing your lab numbers, and promote conversations between patients and their healthcare team. I encourage you to visit our website at www.ruok.org to access our various resources to help get the word out. Our campaign toolkit, infographic, and fact sheet are available in English and Spanish. Please take a minute to answer our potassium check quiz and check out our pocket guide to managing high potassium. You can also use our proclamation letter template to make this day official in your own state. Please also follow us on social media at RUOK 5.1 for all the latest news and tips for managing your potassium levels. I'd like to now introduce our first speaker, Dr. Sydney Smith. Dr. Sydney Smith is a doctorally prepared nurse practitioner, board certified as a family nurse practitioner and certified as a nephrology nurse practitioner. She is on the medical advisory board for the National Kidney Foundation, serving the Alleghenies, the chair of the West Virginia Multidisciplinary Chapter of the NKF, secretary of the NKF's Council of Advanced Practitioners Executive Committee, and is the incoming chair designate for the Specialty Practice Networks of the American Nephrology Nurses Association. She has published and lectured extensively and was the 2019 recipient of the Tim Pool Award, the highest honor the NKF has for nephrology advanced practitioners. Thank you so much for joining us today, Dr. Smith. We look forward to hearing from you.
Thank you so much. I'm going to see if I can get my slides to pop right up here. And while they are doing that, what I want us to do is I want us to step back. And Aaron's alluded to this already so well about how the kidney kind of works to begin with. So if we look at the slide of the kidney basics, and we start over on that left side, and we look at kind of how small the kidneys actually are, but even though they're really about the size of our fist, they actually get 25% of the blood flow right off the heart, goes straight to those kidneys. But if you look at the weight of the kidneys compared to the fact they're getting a fourth of the blood off that heart, they only really weigh 0.5% of the total body volume, but they're getting all that blood flow to them because what their job is to clean that blood, get rid of that fluid, balance those electrolytes. Now, how do they do this though? So as we move across this slide and we go over to that right side, we're going to start talking about the nephron. And that nephron is so critical to how the blood actually gets cleaned. And hopefully this light's going to pop up here in just a second. So the top part, if we're looking again at the big picture of this kidney, and if you see that little tiny box on the bottom, we're going to go all the way down into the cellular level to look at the nephron. Now, the nephron is the big filtering unit of the kidney. We have approximately 1 million of them in each kidney. And if you look at that picture, that is one complicated looking system, isn't it? And it really is. These nephrons are extremely, extremely complicated. And you see that little red ball that we call the glomerulus, that's a tuft of blood vessels. And they're very small. All that blood's going to hit that kidney. And if we look at what happens with blood flow in the kidney and the body, in the period of 24 hours, the kidney actually cleans the blood around 400 times. And if we think about all the fluid that's entering the kidney, really what the kidney's going to work with is about 200 quarts of fluid during the course of the day, reabsorb 198 of it, and excrete about 2 quarts of it as actual urine. So a lot is going on in this kidney, and so it's all the way coming down into that nephron itself. So we get into that blood hitting the nephron. We want to get it back into the bloodstream. Fluid's going to go to those complicated tubes that you see there, and that is a very complex process of absorption and reabsorption of the very important nutrients and fluid. And there's a reason I'm really wanting to focus on that, because when we think about kidneys and how well they function, there are two very important tests that we want to know about. We want to know how well our kidneys actually filtering the blood. And this is what we kind of like, how well are we getting clean? And how we do this nowadays is something called the estimated glomerular filtration rate. Now, we say that word estimated because that's what we're doing. We can't get in there and actually measure it, so we're estimating it. Now, this filtration rate is a blood test that is based on a blood test, but what it actually is a math formula. And I'm not going to torture you guys with the math, but what it allows us to do is look at your physical kidney number, something called your creatinine, but put it into context with the uniqueness of you. So we want to think about somebody's gender, we want to think about somebody's age, because we really want to get an accurate idea of where is the kidney at, how well is it working. The second thing we want to know is the kidney showing signs of protein leakage? In particular, we're looking for something called albumin. So the reason that's important is if kidneys, you want to know, where am I at? How well am I cleaning my blood? But then you also want to know what's going to kind of happen down the road in terms of what we call progression. And when we look at this, when we look for this urine albumin creatinine ratio, we call it an ACR for short. What we're actually doing is looking at a urinalysis, but microscopically for loss of a type of protein called albumin. If we see that we're spilling albumin into the urine, I always like to compare it to finding coffee grounds in my coffee pot. I don't want to find coffee grounds in my coffee pot. If I do, I got a busted set of filters, right? We don't want to see that. And that's because, why do we not want to see it? Well, if we're seeing it, it's actually one of our earliest warnings that something's going on with that kidney. We're thinking about that glomerular, something's going on in there. And it can also occur before the kidney function itself starts to decrease. And this urine albumin creatinine ratio, this elevation, unfortunately, is very, very common in kidney patients. And the reason that's a particularly big deal is the more of this albumin that's spilling into the urine, the faster we can lose kidney function. And that's what this crazy looking slide I just put up. Oh, see, I don't know if we can scoot back to that, Baron. You can pop that slide back for me just a second. What that was is this is what's called the heat map. And I'll give her just a second here. Thank you so much, Erin. So what we're looking at with this slide is what is called the heat map in my line of work. And if you'll notice, it kind of looks really crazy and complicated, but it really isn't, because what we're looking at over on that left side is where is the kidney function at. Again, we're thinking about that GFR. The weaker the kidney is getting, the lower the GFR is dropping, the higher our risk for prognosis of the kidneys to go into the dialysis range, into the need for transplant range. We're trying to slow that kidney loss. We want to preserve kidney function. If we're spilling a lot of protein, if we look at the top, we're talking about that albuminuria, that's that protein spilling. And the more that's coming out, the faster that kidney can be tore apart. And so you can see what you don't want to see is you don't want to see that red, because what that means is we are at really, really high risk for progression of the kidney to the need for dialysis and or renal transplant. That's really kind of what all that stuff says. Now, this is a little older slide. The newer ones, what actually we found is we want the numbers on the top to be lower. We want less and less protein spilling than we used to think. But I like that slide because that red just really jumps out and stands out at you. So what is potassium? You know, that's what we're here for today to talk about. Well, potassium is an electrolyte, and electrolytes are an electrically charged mineral. And as Erin already alluded to, it is a critical for in terms of muscle contraction and nerve conduction. Potassium plays some other important roles, but these are the big ones. Now, if we think about potassium in the body, our body actually has a lot of potassium in it. And the current thought is for every kilogram that we weigh, which is 2.2 pounds, I think we prefer to say kilograms because it makes us look smaller. But if we look at every kilogram in the body, the thought is there's about 50 milliequivalents in there. So translated, if you weigh 154 pounds, you got about 3,500 milliequivalents of potassium in the whole body. Now, where is this potassium at? Well, 98% of it is stored inside the body cells itself. Only 2% is actually outside of the cells. And this difference between where the potassium is really important because that's part of a triggering mechanism, a communication mechanism that tells muscles to contract, nerves to work the way they're supposed to properly. And this is this whole big complex. If you remember your biology class in high school, what's called the sodium potassium ATPase pump, we're not going to get into that, but it's important to realize this, we need that big difference. That's how it knows to communicate properly. So as we think about what happens when we get potassium, you know, how do we get potassium? Well, we're eating it, we're ingesting it. And we have really good bodies at ingesting and absorbing potassium. So almost all the potassium that we eat in our diet is going to be absorbed into our bodies. Our intestines do a great job of pulling that in. And if we eat a lot of potassium, it's going to get pulled into the system, but blood potassium is going to start rising. Well, the body doesn't want it to go up too fast. So there's all these great defense mechanisms in place. So the body's going to take that potassium, it's going to very quickly shove it into the skeletal muscles. And that's really where most of the potassium is stored, is in these skeletal muscles. And it's going to hold it there until we can balance it over the long haul. Let's call this potassium homeostasis. So we're going to hear a lot about kind of watching our diet and kind of trying to balance it. And that's why, because we're going to be talking about this weakening kidney that can't really manage potassium well as it's weakening. And how much does the kidney control potassium? A lot, 90%. of potassium balance is controlled by that kidney. Now your gut's in there, it's going to try to help, but the GI tract can only really handle about 10% of that. So the big impetus is on those kidneys. And so even normally functioning kidneys are going to take several hours to actually be able to excrete the potassium. So it's not a fast process in shifting it. So where should potassium be? Well, actually pretty tightly controlled. So if we look at the middle graph there of what is a normal potassium level, it should be between 3.5 to 5. And some labs vary that a little bit. I've sometimes seen as high as 5.1. But it's usually around in that ballpark. You don't want potassium to get too low. That's not a good thing, because again, remember, we have that communication issue going on. So too low is not great. But where do we usually see the problem with potassium? Well, it's the high potassium issue. So once we start to get above 5.1, we consider this to be high potassium. And this can be defined as either mild, moderate, severe. And where do we usually start worrying in kidneys? Well, we don't like it going up above 5.1, but really once we start to see these 5.5s, we start to get worried. You start seeing 6s, oh my gosh, we're really worried. You get a 6.5, oh my goodness, now we're really panicking, because we worry about, again, this miscommunication that's going to start to occur, because that blood potassium's going up, that cell's like, wait a minute, are you trying to trigger me? Is something trying to occur? All right. So if we look at how the kidney works with potassium, again, it's got 90% of the control of it. This is a very complex process that occurs. And really, kind of unfortunately, at the end of the day, what happens is as that kidney is weakening, we're going to see problems with the kidney in terms of being able to manage the potassium. You know, if you have CKD, you already know a lot of stuff goes wrong when kidneys weaken. A lot of stuff can go wrong. And one of them, unfortunately, is this potassium control. And that kidney is going to do an incredible job as the kidney is weakening to compensate. It's amazing, the compensatory mechanism of the kidney, but at some point it's not going to be able to do it. It really, where we start to see this of particular concern is when that filtration rate gets below about 20. And so if you're familiar with those GFR stages, those kidney stages, we really worry about the need for dialysis once we drop under 15. So we're talking usually as the kidney gets more and more advanced, we'll start to see this become more and more an issue. But it can occur sooner than that. Not very common, but it can occur. At the same time that the kidney's weakening and the potassium is starting to not be regulated, the gut will try to jump in and help. It just can't do it as well. So at some point, we start to see issues with inability to really control the potassium the way we would like to. And then I'll point out things are complicated, because it's not just the kidneys that this is a problem with. If you're diabetic, if you have congestive heart failure, just having those alone increase your risk for having an episodes of high potassium. And really, if you're unlucky and you got congestive heart failure, diabetes mellitus, and chronic kidney disease, all those together, that just adds up even higher the risk to have these episodes of a high potassium. So it's really additive with it. And unfortunately, we see a lot of that in people who have chronic kidney disease. They often have comorbid conditions that set them up. Now, if your kidneys are at the level that you require dialysis, we are really dependent upon the dialysis as well as that low potassium diet to keep that potassium level controlled. Think about it. We can't really trust the kidney to do it. The kidney's not able to do it. And so we really have to make sure we're getting in our good dialysis, getting that adequacy up where we want it to, and making sure we're really watching the potassium in the diet, because again, we don't have those regulation mechanisms kicking in. As you've probably picked up on, high potassium episodes are actually common and reoccurrent, especially in advanced kidney disease. If you look at studies, if you have an episode of high potassium, within a year, 50% of people will have one episode. Okay, just the one. Not great, we don't want to have any, but about 50% will have 2 or more. And what they found is in certain patients, particularly with all those risk factors, they found some patients could have up to 20 episodes a year. That's not a lot of people who do this, but that can actually happen. So this can be a reoccurrent process with this high potassium. And what kind of causes a problem with the potassium going up too fast. What's the big deal with that? Well, again, we don't want to cause this triggering mechanism to occur where the heart doesn't know how to beat or how to work properly. And what's going to mess that up is, again, the balance between what's in the cells and outside of them. We also have to think about how fast did that potassium go up? Is it this little increase that body's kind of trying to compensate and adapt for, or did it go up really fast, which is going to can precipitate one of these events we don't want to see? The other thing is we may have other issues going on. I didn't say kidney disease was fair because it's not. We can see problems with acidity in the blood. The kidney can't always get rid of acid. It's got a lot of jobs, the kidney. And if that blood's running on the acidic side, that means it's setting you up for a high potassium episode. So if you've ever been given sodium bicarbonate, one of the things you're doing is actually helping prevent a high potassium episode besides getting rid of the acid. Unfortunately, if you got bad kidneys, you're set up for a lot of things like a GI bleed. And with COVID, I have never seen so many GI bleeds in my career where we've seen big spikes in potassium and the patient had a GI bleed in there. But certain medications can also trigger high potassium episodes. And we're going to touch on what some of the big ones that do this. Obviously, drugs that have potassium in them, you're going to do it. So you don't want to be taking potassium supplements if you're having high potassium episodes, but not all drugs that have potassium in are used for potassium supplements. For example, kidney stone prevention. Drugs like beta blockers, heparin, we have potassium-sparing diuretics, digoxin. Some of our immune suppressant drugs we use in transplant patients can cause high potassium episodes, but they're literally life-saving. So we want to think, we have to use them a lot. But you'll notice I've got 3 of them bold and highlighted for you, and there's a reason for that. These drugs are part of what we call RAS inhibition. These are ACE inhibitors, all ACE inhibitors pretty much in pril. So lisinopril, captopril, your angiotensin receptor blockers, another big important component of what's called RAS inhibition. These all end in sartan, so losartan, for example, valsartan. These are ARBs. These are your 2 big ones. And we'll often use what are called mineralocorticoid receptor antagonists. You don't have to remember that. But these are drugs like spironolactone, which are actually very, very important in blood pressure management and heart failure treatment. So this RAS inhibition therapy, I want to touch on this because RAS inhibition treatment is absolutely baseline, guideline-based, important for treatment of a lot of very, very challenging, difficult things to live with. For example, congestive heart failure, where the heart is just not beating properly. If we've had a heart attack, we want to protect that heart, help it heal. Some blood pressure is so hard to control, you have to use certain drugs to bring it down. And unfortunately, the kidney disease, we go into kidney disease. If we go back to that slide I showed you, that heat map, remember we're spilling protein, we're spilling protein, we're spilling protein. I want to slow that down. You know how we do it? RAS inhibition. We use ACEs and we use ARBs. They are going to slow it down, but they're going to come possibly at a cost. They're going to slow down blood flow in the kidney, and that we also may see that potassium go up. But why do we use them? Well, we use them because it reduces the number of cardiovascular events. That means that we're protecting your heart. We're going to slow down loss of kidney function. We're going to slow down that progression toward dialysis level. And it also really does reduce the risk of death. And we call all causes is kind of what it sounds like. We want to bring down that mortality. Now, in the past couple of months, we have had massive change in nephrology. And when we talk about guidelines, to give you a little background on this, and I'm not going to read this thing to you. This is actually part of my guidelines we use in nephrology. This is from something called the Kidney Disease Improving Global Outcomes. You can go right to their website. They have multiple guidelines. We use this to help guide our care of patients who have kidney disease. This is a worldwide effort because everybody got kidneys. So we look across the planet. We look at all these studies. They spend hours and hours and hours tearing these studies apart to figure out what can we do to improve the quality and quantity of life for people who have kidney disease. And that's what these guidelines are. So around October 2020, the diabetic guidelines were updated and came out. And you'll notice I bolded all those things with ACE and ARBs. And what we know, and because these drugs have been used for long enough now, is what I was telling you before. They're going to slow down progression of the kidneys to dialysis level. They're going to protect the heart. And we really, really do want to use them if we possibly can. Now, I want to put out there's a caveat with these drugs. You really don't want to use them in somebody who's looking at getting pregnant. Because if you're considering pregnancy or are pregnant, you don't want to use them. They are not friendly at all to a baby. Those are not good drugs, but we want to use them if we can. And the reason I'm bringing this up is you may start to notice or hear, your healthcare providers talking to you about drugs. You may have been on these drugs in the past, and they've had to pull them because of the high potassium. But there's thinking about, wait a minute, should we revisit this? Are we able to put these back on? Are we able to control the high potassium? And honestly, we've gotten better at it. So what you're looking at on that table is actually, again, from the guideline of some of the things that we can do in healthcare to help improve that. Of course, you play an absolutely critical role with this. So, if you ever wondered why are they giving me fluid pills, or why am I getting something like sodium bicarbonate, ask these questions, because what they may be doing is trying to allow you to use a medication to protect your kidneys from itself. And to really keep things entertaining, first part of March of this year, the blood pressure guidelines got updated, and a lot of what I was just telling you about with use of these drugs again came to the forefront. And we found, unfortunately, in the United States, we're not utilizing them the way they should. So you may be hearing this and bringing this, and having this brought up to you. And I only brought up part of the guidelines. Again, a lot of material there. I love how they bullet point it. This was for patients who have chronic kidney disease with or without diabetes that aren't on dialysis, because dialysis just changed the dynamics. But again, this idea of trying to protect the kidneys. And when we look at this, we look at the studies, we know we're just not using these drugs. We're just not doing what we need to, because we're honestly concerned about high potassium. And so if we have high potassium, it really can lead to some very serious life-threatening conditions. Again, if we think about the lack of, we're triggering this communication between the cells. They're thinking, oh, should I be contracting? It can cause paralysis of the diaphragm. We can literally go into respiratory failure. The heart can just not know what to do, can throw itself into a fibrillation where the heart's just throwing itself like crazy, can lead to heart attack, can lead to sudden death. And I always get the question of, oh, what are the symptoms of high potassium? Well, here's the problem. A lot of times you don't have any. That's the problem. Or they're so subtle, you don't pick up on them. Or the problem is the symptoms of high potassium often look like low potassium. And what people do, they think, oh my gosh, I need to drink me some orange juice, or I need to eat me something with high potassium, because the symptoms are very similar. So what you can sometimes see is this muscle weakness, this twitching, this cramping. So essentially, a lot of people say, oh, you're cramping, you need potassium. You may actually have a high potassium. And how do you know? You're going to have to get a blood test. We're going to have to check that blood. So important, if you really think, hey, I think my potassium might be up, get it checked. Get it checked. And hopefully we can avoid the emergency room or hospitalizations. Don't trust an EKG, by the way. Occasionally I get a patient think the EKG will show up. They don't need that blood test. They don't want that. EKG is going to miss a lot of these characteristic changes that we look for. And these huge 6.5 numbers, about half of patients did not show these characteristic changes. So you really got to get that blood checked. That's very, very important. And there's nothing wrong with getting that done. Emergency treatment of high potassium, I'm going to touch on it very quickly, because if that potassium goes high, we think that heart's involved. We have to protect the heart first thing, and we got to do it fast. And how we actually do it is we give calcium. Now, all that calcium is going to do is just going to protect the heart. It's going to say, okay, heart, don't do something stupid. Don't go into fibrillation. Don't stop beating. I'm going to protect you. But what have I done with the potassium? Well, nothing. So we have to shift the potassium into the cell. So we use a lot of the mechanisms the body uses. One of them is using insulin. I know it sounds crazy. If you've ever wondered why if you have diabetes and you keep talking, let's get this sugar down, let's get the sugar down, let's get that, if you need insulin, let's make sure we're using it. Insulin actually helps drive potassium into the cells. And we're going to give it, a lot of times we'll chase it with sugar because we don't want to drop your sugar too low. We can also use albuterol. We're not talking the puffer, with your inhaler. It's actually a really big dose to drive in the albuterol. So we can drive it in, but again, it's going to shove it in, but it's not going to keep it in. It's going to come out. So we got to figure out what to do with where it's built up too high. So we got to think about removing the potassium from the body. And this can be done with things like loop diuretics. Furosemide, a common one. Sometimes we have to dialyze people who haven't needed dialysis before to get it out. It will pull it out, but if something was causing it to build up, it'll start to build back up again. touched on sodium bicarbonate. A lot of people don't realize how important that actually is to get rid of the acidity in the body. And hopefully we'll have newer medicines soon besides sodium bicarbonate to help treat with this. And we're also starting to be able to utilize more effectively what's called potassium binder therapy. A lot of people are familiar with the first one. Sodium polystyrene sulfonate is a drug, brand name is KXLate. Fortunately, it can cause a lot of GI effects for people, but it's been around for 50 years. But we have newer agents now. We have sodium zirconium cyclosilicate and patiramir that both work in the gut. All these work in the gut. They're going to grab potassium and they're going to get it out. So again, we're using that GI tract to our advantage like we did before. Long-term management of potassium, if we're having high potassium episodes, we're going to be thinking about, can I use a fluid pill to pee some off? A lot of times we can use those because we're usually holding some swelling and kidney disease. We may have to go back and think about getting rid of drugs I don't want to get rid of, or dropping doses I don't want to drop. Remember all that big kidney protection, and that's an important thing to be aware of. We're losing protection. If those drugs are going to benefit you, we have to pull it back. We are losing protection. We don't like to do that. We can help, but we want to protect you. We do have newer agents now, which is great to be able to bind the potassium. And of course, key is this idea of this dietary reduction of potassium and trying to balance that and kind of keep that balance. So I appreciate your time and attention for my portion, and look forward to hearing what the rest of my colleagues are going to share with you.
Thank you so much, Dr. Smith. I always enjoy your presentations, and just as a reminder for people who maybe didn't check out our webinar last year, you gave a great presentation last year as well. So thank you again for joining us today and talking about potassium and how important it is to maintain those levels in a safe zone. I'd like to now introduce our next speaker, Carolyn Feibig. Carolyn is originally from St. Louis, Missouri, and has been a dietitian in the Washington, D.C. area since 2011. She is currently the kidney transplant dietitian at the George Washington University Hospital. She has also worked as the dietitian in a dialysis facility. Carolyn found her passion for renal nutrition when her nephew was born with only one working kidney. Throughout her career, Carolyn has sought opportunities to educate the general public about the importance of early detection of kidney disease and the benefits of a healthy diet and kidney health. She is a seasoned presenter at the American Association of Kidney Patients National Patient Meeting and our Policy Summit. Carolyn volunteers her time with and speaks at events held by the National Kidney Foundation and American Kidney Fund, and also teaches renal nutrition to Virginia Tech at the DC campus and Mid-Atlantic Sodexo dietetic interns. Carolyn has a passion for good food, be it a tried and true recipe, making something for the first time, or going in search of new and delicious restaurants or farmers markets. Thank you so much for joining us today, Carolyn. We appreciate you being part of this webinar.
Yes, Erin, thank you so much, and thank you to the AAKP for letting me speak on this topic again. Like you said, it's something very near and dear to my heart, and I'm sorry that I'm having, some technical difficulties, so you won't be able to see my beautiful shining face, but, just imagine Christy Brinkley. All right, let's get going. Let's see now. Hopefully my technology will be working. Voila, look at that. All right, so I'm going to be talking about everyday kind of tips and tricks on how to follow a low potassium diet, right? So I love numbers. I love to follow the rules. I love all these things. So I really would want somebody to sit here and tell me exactly what I needed to do to follow a low potassium diet. So we're going to be talking about, like, what does it mean to eat a low potassium diet? What are those magic numbers that you need to be striving for? What can you actually eat on a low potassium diet? Because that picture there that I'm showing you is a whole bunch of foods that are really high in potassium. And hopefully your dietitian has said, oh my goodness, don't ever eat an avocado. They're so high in potassium, even though they're super good for you, right? It's kind of that flip side when you're trying to focus on a low potassium diet. So what can you eat? Well, meal planning is a big important part that we're going to talk about. Serving size, does that actually matter? And then what can you do to kind of lower some of these potassiums on higher potassium foods? So a low potassium diet, and like Dr. Smith was talking about, we all got a whole bunch of new recommendations out recently. She was going over the KDOKEY guidelines, which are worldwide. These are the KDOKEY guidelines, which are actually from the National Kidney Foundation, and really it's kind of what the United States is focused on. And KDOKEY stands for like the Kidney Disease Quality Outcome Initiatives. We just call it KDOKEY. It's much easier that way. But basically, they're talking about how, like, in any form of CKD, stage 3, 4, 5, non-dialysis, dialysis, and even post-transplant, because like Dr. Smith was saying, these transplant medications can raise your potassium levels. It's reasonable for us as dietitians to help kidney patients and for kidney patients to be following a adjusted dietary potassium intake to help maintain those normal levels. So what does that mean? I mean, it's all about trying to do individualized medicine now, which I think is wonderful, because what I want to eat is not what Dr. Smith wants to eat, nor is it what Della or Jane want to eat, right? That's what makes the world go round, right? Is all of our individuality. So, and these new guidelines, they're really, like I was saying, trying to get away from these hard numbers and focus on individualized care. However, you got to know these numbers too, right? I mean, I'm going to be writing these things down and whatnot and like tracking everything, but it's good to have these ideas in your head. So for somebody who has high potassium, who might be at those later stages of kidney disease, or you've gone to your nephrologist and they've said, oh, your potassium's a little bit on the higher side or it's creeping up, your daily total of potassium intake should be around 2,000 milligrams. So what does that mean? How do you eat 2,000 milligrams? Well, a single serving of food that's going to be considered a high potassium food, those bananas and avocados and oranges and, you know, juices and things like that, they're going to be over 250 milligrams of potassium. But that doesn't mean you only have to have 250 milligrams of potassium in a meal, right? Because that would be really difficult. So per meal, you're looking to have about 600 to 700 milligrams of potassium per meal throughout the day. If you hit the 600 milligram level in your meals, then you can add in some snacks. If you have a higher potassium meal, then you want to cut back on some snacks. But that's going to give you around 1,800 to 1,200 milligrams of potassium per day. And actually, I mean, like, they've even shown that people who don't have a low potassium need or diet, and, you know, who follow a Western diet, are actually eating around 2,000 to 2,500 milligrams of potassium a day, because unfortunately we're not eating enough fruits and vegetables and all those good high potassium foods. But so, I mean, it might seem more daunting than it really needs to be. And also it's important to know that everyone is different, right? We like to eat different foods and our bodies all act differently. And so our kidney function is different. So you might be sitting at this with the same GFR number, but you might have different levels of leftover or residual kidney function, even if you're on dialysis. So like, you think about it, like some of you might still urinate, but some of you might not. Some of you might need to take 5 different phosphorus binders with your meals, and some people might only need to take 1 or 2. Some might not need to take any. Same thing goes for potassium. So some people might have some leftover kidney function and they're still urinating and their kidney is still getting rid of some of that potassium. Some people might still be urinating, but their potassium levels might be elevated because really that kidney is not balancing out those electrolytes, but it's just removing that fluid. And some people are not having any of that, you know. So it really all is working with your dietitian. It really should help you manage that, and so that you can include some of these higher potassium foods that you might really miss, like tomatoes or possibly an avocado. Nah. So what can you eat? Almost anything, really. I mean, like, and that sounds Like, wait a second, that doesn't make any sense. We're not supposed to be eating those high potassium foods, and that doesn't make, how can I do that? How can I eat almost anything? Well, what you want to do is you want to choose foods that are going to keep you full, right? You're going to want to choose foods with fiber. You're going to want to choose foods with some protein, some of these healthier forms of fat, because those are going to make you eat less, because you're going to feel full faster and you're going to stay full longer. Then think about your lower potassium foods, like the pineapples and the carrots and the lettuce and the raspberries and the broccoli. You're going to want to eat bigger portions of those. And then your higher potassium foods, like dried fruits, like those dried cranberries that you might want to put in your salad, or some avocado or cooked spinach or bananas, you would choose smaller amounts of those. So that way you can still have that little bite here and a little bite there. Cheese is a big one, right? It's high in potassium, it's high in phosphorus. It's, you know, we dietitians in the kidney community are like, no, don't eat any cheese. But you get those bigger, bolder flavors of cheese, that blue cheese, those stinky, you know, Limburger cheeses, right? A little goes a long way, and that way you can manage having a little bit of that satisfying cheesy taste instead of not having it and feeling deprived. So portions, do portions matter? Absolutely, these portions matter, right? So these foods that we eat have, I mean, pretty much potassium is found in everything, right? We tell you to eat a lot of meat and fish and things like that. Well, those are also high potassium foods. So how much potassium are you getting? Well, it all depends on how big your portion is, right? So you should be thinking about 3 to 4 ounces of meat is really considered what we consider a serving. Well, that's about the size of a deck of cards, or the palm of your hand, not the full hand, but just that palm part. That is about 3 to 4 ounces. One chicken thigh is 4 ounces. That is how much portion of meat you should be having. And that will help balance your potassium, because meat, surprisingly, is very high in potassium. Those lower potassium vegetables, you get a cup. So it's about a baseball size or an entire fist. So if you hold your fist, it's your entire fist, not just the front of the fist, but the entire fist. And that would be, you know, like lettuce, it's so low in potassium, you could do 2 fistfuls, right? And you could make a big salad with a whole bunch of like iceberg and romaine lettuce, right? You know, my mom always said, oh, don't eat iceberg lettuce. It has no nutrition, it has no nutrients. Well, great. That's great for people who are trying to eat a low potassium diet, right? So you fill up on that iceberg lettuce and that romaine lettuce, and then you throw in some spinach, some raw spinach, right? So you can have that little taste here and that little taste there. Fruit. Fruit is very important. Fruit actually is really good for us, but it's pretty high in potassium. Most fruits, even the lower potassium fruits, are pretty high in potassium. So you want to have a small fruit, like a small apple, not that one of those big ginormous apples that you see in the grocery store that are almost like the size of your head. I mean, you want to get one of those smaller little fruits, that little dinky apple that no one wants to buy. That's the apple for you, right? That's going to help manage that potassium. Cheese, like I was talking about, buying those stinky, full flavored cheeses. And an ounce of cheese is a serving size. And surprisingly, if you only eat an ounce of cheese, it's not too high in potassium or phosphorus. But I mean, you know, I always say feta makes it better, or Gouda makes it Gouda, you know, right? It's so good, it's Gouda, right? But I mean, like, so we put on a lot of cheese, but if we dial back and just follow the serving size, that would work. Rice and pasta, those are actually fairly low in potassium, but a serving is a half a cup, which is like, if you make a fist, it's like the front of your fist. That's about the size of a half of a cup. And it was interesting because Dr. Smith was talking about how when you have really high potassium, they will, and you're in the hospital, they'll have to shift your potassium from your blood into your cells And they do that with dextrose, or like sugar water, and insulin to help drive that potassium in. Well, if insulin moves potassium into our cells, if we eat foods that are going to stimulate insulin, like carbohydrates, that could help move that potassium into your cell. Now, am I telling you to eat 2 cups of pasta like I would like to be able to do? No. Wouldn't that be great? But I mean, that could help. Maybe you could have some chopped up tomatoes, and not tomato sauce, but some chopped up tomatoes in that pasta, and that might help move that potassium into your cell. Also, nut butters, right? We talk about peanut butter and like, oh, you can't eat peanut butter, you can't eat nuts, this, that, and the other. Well, choosing smaller amounts, right? So a teaspoon, which is not a lot, but maybe you could even do 2 teaspoons of peanut butter. That could help. Surprisingly, chunky peanut butter has less potassium than smooth peanut butter, because if you think about it, per volume, because there's these bigger chunks of peanuts in there instead of like that smooth peanut butter, which is a lot more ground peanuts per tablespoon. And so portions so like I was saying, portions matter, and I was talking a lot about meat, right? And we dietitians are always like, oh, well, you got to eat that high biological animal protein. Your albumin's really important, and you got to eat this meat, and you got to eat this meat, and meat. I mean, I kind of agree with that. I mean, I certainly am a fan of, I'm a carnivore, but maybe we don't need to eat as much meat. Not maybe, we don't need to eat as much meat as we in the Western diet think that we do, number one. Number two, on dialysis, there's a lot of different factors that affect your albumin, and some of it's not just eating meat, right? And it's hard to raise your albumin, and people are like, oh my God, I'm so sick of chicken, X, Y, and Z. Well, and you think about it, meat's also really high in potassium. So if you're struggling with potassium, and you're eating a lot of meat, that could be one of the issues. So I went to the USDA website and did a little bit of digging, and 8 ounces of a sirloin steak. I mean, I feel like that seems like a portion that we would go out to a restaurant and we would get an 8-ounce steak. That is 850 milligrams of potassium. And more and more evidence has been coming out about what's called bioavailability. So like, how much of that potassium are we absorbing in our guts? Well, sorry folks, we absorb about 90 to 100% of the potassium in meat. So that 805 milligrams of potassium in that meat, you're absorbing almost all of it. So cutting it down, trying a 4-ounce sirloin steak, I mean, because if you think about it, you still get 600 to 700 milligrams of potassium per meal. So you could do that. Or you could choose a different type of steak. Plank steak has just a little bit less, but that would be good for some fajitas or whatnot. Chicken. So chicken, you could choose chicken over a steak. It doesn't really do that substitution, but 1 full chicken breast, which is actually from the base of your hand to the tip of your middle finger, is 440 milligrams of potassium. So you could eat a half of a chicken breast, which actually is the appropriate serving size. That's about 3 to 4 ounces. And that is actually a lower potassium food. It's not considered high potassium. Or you could eat 1 thigh, which is 3 to 4 ounces and about 300 milligrams of potassium. Salmon. Everybody talks about salmon, right? Salmon's so delicious. It's full of these omega-3 fatty acids. It's good, heart healthy, all of that jazz. It's high in potassium. It's one of those higher potassium fish. So instead of getting a 5-ounce fillet, you do a 3-ounce fillet. You could flake some salmon into your salad of iceberg lettuce with a little bit of spinach, right? And a few sliced strawberries and whatnot. That would be delicious. Some red onion and maybe some capers. I don't know. But that's how you could get your salmon fix. Or those extra jumbo shrimp, those like 26 or what, 16 to 20 shrimp, and that's, you get 16 to 20 shrimp per pound, so that means that they're big, delicious, juicy shrimp. Well, you can have 3 of those, and that doesn't sound like a lot, but it's, because they're big, that's actually a pretty decent size, and that would be about 220 milligrams of potassium. Turkey, right? Turkey, I was shocked at this. I mean, I dug around and I looked and I looked and I looked and I looked and I went to all these different USDA turkey wings, with skin, without skin, this roasted, fried, this, that, and the other, and they were all saying one turkey wing is almost 800 milligrams of potassium. I was floored. So you could eat a half of a turkey wing. I don't know if I could do that. But I certainly could have about 3 ounces of turkey meat, you know, from the breast, probably also the thighs, probably also not as, you know, maybe a little bit higher. But those are all things that are ways to cut back on potassium because of this meat. And when you're like, but I can't do that, I got to eat my protein. Drink less fluid. That masks your protein level. So like the more fluid you have on you, the lower your albumin's going to be. So there's that. But then what about plants, right? So how do you focus on, how do you do this with plants? Well, yeah, bananas. We you know, people swear off of bananas. I can't eat a banana, but that's actually, one medium banana is less than that 8-ounce steak. And that banana is going to help encourage, it's going to increase like your insulin production in your body, and that's going to drive that into your cells. It's also full of fiber. Now, I'm not telling you to go out and eat a whole bunch of bananas. Believe you me, I am certainly not doing that. But if you love bananas, have a half a banana in your cereal. That might really just like turn your life around and make you feel like, hey man, I got this. An orange, one orange has actually only 230 milligrams of potassium, and we consider high potassium foods to be anything over 250. Yeah, so I think oranges got a bad rap, number one, because people drink orange juice and you're going to absorb that potassium really quick because there's no fiber in there. And that's just going to spike your blood sugar, and it's going to spike that potassium and things like that. So, and let's say you're somebody that maybe you do have high potassium, so you really should be watching out even for those potassiums that are foods that are in that 250, a little bit lower than that. Try a clementine. Those things are delicious. Eat one of them if you can. Large peaches, right? Try a small peach. Remove the skin of these fruits and vegetables. My mom always said, oh, eat the skin. It's where all the nutrition is. Well, remove the skin. It's where all the nutrition is, right? You know, butternut squash. You could chop it up. And you know, like the whole thing is, it's about like reducing the size when you're cooking. So like if you eat a cup of cooked butternut squash, well, you're actually eating more than a cup of raw. So take a half a cup of raw butternut squash, cook that, and then eat the remainder, right? So it's going to shrink. There's shrinkage involved when you do that. Or instead of choosing one of those hard winter squashes, like the acorn squash or the butternut squash, the kind that, you know, you knock on it, it's hard. Choose yellow squash, the summer squash, those crook neck squashes. And yellow squash actually has less potassium than zucchini. So choose yellow squash over zucchini even, but zucchini is good too. And beans, right? We tell you don't eat beans. Oh my goodness, beans are the worst. Well, white northern beans are. They have 920 milligrams. That is the topper, right, on the potassium scale for all of these foods that I've just talked about. So try half a cup of black beans. That's 370 milligrams of potassium with some rice and some yellow squash and maybe some like tomatillo salsa. That sounds delicious, right? Make a little burrito out of that. You can have some pinto beans as well, but it's all about a half cup. If they're canned, rinse them. You're going to rinse off the sodium. You're going to rinse off some of those extra, like some of that, all of those other preservatives. Boil them again. Drain that water. That's going to remove some of that potassium. And one of the reasons why the bioavailability of the potassium in the foods in these like fruits and vegetables, are they're bound by what's called phytates, and our body can't absorb phytates. Now, cooking breaks down these phytates, so you're going to absorb more. So raw always is better, but no one's going to be eating raw butternut squash, right? No one's going to be eating like dried beans, right? So, so I mean, like that's why you measure first and then you cook. So how to lower some of the potassium in the foods that you eat? Fruits, like I said, peel the skin. Hard vegetables, it's just like how we call it, dialyzing those potatoes. You can dialyze pretty much anything if it's a hard vegetable like that butternut squash or that acorn squash. You peel it, you dice it. The smaller the dice, the more potassium you can lose. You soak it in water overnight. I like to do both, right? The soak overnight and the double boil. It's going to remove a lot of that potassium. So you peel it, you dice it, you soak it in water overnight. You drain that, you rinse it, you boil it in 2 times the amount of water. You rinse it and you boil it again in 2 times the amount of water. Here's the deal. Potassium likes to be even, right? It likes everything to have the same amount of potassium from one liquid to the next. So that potassium in that potato or that squash is going to move from the center out to that water to balance everything out. That's why it's an electrolyte. It's electric, and then they like to balance. It likes to be balanced. It likes everything to be like a net electricity type of deal. So the smaller the dice, the shorter the amount that potassium has to move. Limit or avoid juice in general, even if it's one of those lower potassium juices. They're full of calories. I like to eat my calories, and they're full of, no matter what, they're full of potassium, and they have no fiber to help slow it down. You're just going to absorb that. That's why the oranges and orange juice get such a bad rap. Oranges, probably not so much. Orange juice, maybe. Greens, right? We always tell you, don't eat any greens. You can't eat any greens. Oh my goodness, don't eat any greens. They're going to be so bad for you, right? Well, you measure, like that picture down there, you measure 1 cup of raw spinach, which actually or a half a cup of raw spinach has 84 milligrams of potassium. So 1 cup of raw, don't pack it in there, but 1 cup of raw is going to have 190 milligrams of potassium, still considered a lower potassium food. And then you cook it, and it's going to shrink down to about a half a cup. You drain out whatever liquid has been released. There's going to be potassium in there. So yeah, you're not going to have a lot of cooked spinach, but you'll have some, and you can add that to whatever. You can eat a little bit, put a ton of garlic and onions in there, delicious. Also, when you're cooking these greens, boil them and drain the liquid. Again, that potassium is going to leach, some of that potassium is going to leach out, or eat it raw. Always delicious. A good spinach salad, any of those greens are good raw. Meal planning, right? If you don't plan your meals, then that's when you fall into traps. I fall into that trap of pepperoni pizza. I'm not gonna lie. So there you go. If I don't have a plan, so pick a day of the week to plan your meals. Write your grocery list. Go through those cookbooks. And then the next day you go to the grocery store, you prep all your food, you make your own, like you can build your own meal kit. You don't need Blue Apron or any of those things to ship it to you. You can do it yourself. Or if not, then you can have that, but that's fine. Choosing renal friendly recipes is important. The American Association of Kidney Patients have these delicious recipe cards, and it has all of the phosphorus on there, it has all of the potassium in there, and then you can figure it out. Make enough for 2 meals, so that way I don't want to cook every night. I mean, like, I'm busy, and even if I'm not, I don't want to be standing in my kitchen doing that. So make enough for two meals, and if you have a family, great. So you make enough for your family of 4 twice. And then the next day you can have it again, or you can use one ingredient twice, right? So you roast a chicken and you have roasted chicken and grilled veggies. Well, the next day you have chicken tacos. I think also mornings can be, we don't want to wake up, we don't want to cook, what do? We grab a donut, we grab a this, we grab a that, we don't grab anything. I don't know. Well, you could make easy to go breakfasts. You could make like egg sandwiches. You can make these little egg muffins. You know, there are lots of things that you can do. You can freeze them. You can keep them in your refrigerator, all sorts of stuff. So I've decided to show you guys one day meal example from these delicious AAKP recipes, right? So these egg muffins that I was talking about, it's these frittata muffins, right? There's 110 milligrams per serving. The other thing that I really liked about these recipe cards are that they, on the back of every single one, there is a potassium check. So there's a little something that you can learn about potassium. But these little egg muffins or egg frittatas, you make 6 of them, you make them in your, like in a muffin tin, bam, 110 milligrams of potassium per serving. So you could have 2 if you wanted to, or they would be a great snack. Again, you can make them in bulk, and now you've got a grab and go little breakfast thing. So breakfast, done, frittata muffin. Next, steak fajita salad and an apple, an apple a day, right? So that actually is the big potassium bundle that you're going to get for the day from here. That's 620 milligrams of potassium. That's still well within range. And here you are with steak and a salad and an apple. Chicken pot pie, one of my all-time favorite things, right? So you could have a chicken pot pie, and as long as you're following the serving size, that's the key. So 400, milligrams of potassium. Then you've got your dessert, a coffee cake, right? 79 milligrams of potassium. So what was your day's total? Well, your calories were only 1,200 calories, almost 1,300 calories. So if you wanted to lose weight, that would help. Your protein, still plenty, 60 grams of protein. Your potassium is well under that 2,100 limit, right? Or goal. So you could add in some more. And look at that. That phosphorus is only 600. If you're eating phosphorus levels around 600 a day, you probably won't need binders. And there we go. I hope that you guys all pictured me like Cindy Crawford, and and really enjoyed my talk, and I hope I gave you some tips and ideas. Thanks.
Thank you so much, Carolyn. We always enjoy your presentations. So our next speaker is Della Major. Della is a resident of Chicago, Illinois. She has been an end-stage renal disease patient since November 2011. Della is a certified kidney health coach for the American Kidney Fund, a facility peer representative for the Renal Network 10, a member of the Patient Advisory Council, a patient ambassador of the Dialysis Patient Citizens Group, a subject matter expert for the National Coordinating Center, Patient and Family Engagement Learning and Action Network, a member of the Medical Review Board for Network 10, a Patient Advisory Council member for the NKF of Illinois, and a very active AAKP ambassador. In 2017, Della received the Robert Felter Memorial Award from the Renal Network. This award recognizes patients who are champions for dialysis and transplant and a guiding force for patient-centered activities. In addition to her kidney advocacy, Della is an ordained minister and elder at her church, Valley Kingdom Ministries International, where she serves as the lead facilitator of the Teachers Training Program. Della has a strong outreach ministry where she volunteers at the local food pantry, who provides assistance to low-income families within the urban community of the city of Chicago. Recently, Ms. Major launched a new business venture called LYVE, which stands for Living Your Victorious Life Through Encouragement and Education. And Della received a kidney transplant in August of 2018. Della, I turn things over to you.
Well, every time I hear just a little bit of my snippet of my bio, that just makes me laugh because it makes me seem like I'm just this super expert. But I'm just very passionate. I'm very passionate patient that really believes in patient engagement and advocacy. So thank you so much, Erin, for just sharing along this line. You know, this I was laughing so hard at Carolyn's presentation because everything that she was saying, I was like, nope. No, I was checking it off because that is one of the things that I know I struggle with. First thing first, you know, yes, I do deal with high potassium issues, even as a transplant patient. I'm going to first start off about my experience while I was in center. You know, the purpose and the cause of my kidney failing was due to systemic lupus, lupus nephritis. And so, you know, I had a lot of complications with that, and especially in the areas of, you know, the health part, you know, where pretty much my eating habits was already bad, but dealing with the complications with that particular disease, they became very poor. So it was to the point where I really was rarely eating. So my body was trying to retain whatever it can retain since I was not giving it the fuel that it needs to be able to maintain. And so all of the foods that's listed was no-nos, but they were my go-tos, like guacamole chips, you know, guacamole dip, you know, bananas, banana pudding, things that was not so great. You know, loaded baked potatoes with all the cheeses and the bacons and everything. So it's a lot of things. I love peaches, you know, raw peaches, cooked peaches, canned peaches. So pretty much all of the foods that that will give me pleasure, that will make me want to eat, was no-nos for me. And so when it came down to being in center, you can imagine what my monthly labs was looking like. First of all, you can imagine how I was cringing every time they say we was about to do labs, because I already knew that it was going to be high in potassium and for sure high in phosphorus. And so those are some of my challenges. Really trying to make the necessary adjustment, one, to eat, and then two, to eat the right things. And so a lot of the symptoms, as you see here listed, is what I experienced on a consistent basis. I was always tired, so weak, always tired. You know, it was just nothing. I barely even had the energy to even want to socialize with my children along that particular line because of some of the flares, lupus flares. But yet, still, even doing dialysis, I always had muscle ache. My body was feeling like somebody had a plastic bag and beat me from the head to the toe with the plastic bag. Every treatment, every time. So cramping, even outside of doing a dialysis treatment, always cramping. And so it got to the point, it was causing so much problem. It had to, you know, my dietitian's like, we got to get this under control. So she was beginning the process of teaching me how to really be conscious of the food intake. Even though I know I was not eating a lot, yet still she brought value to my food. She's like, eat the things that's going to be good for you rather than the foods that's going to be bad for you. I know you have this, you like these things, but you got to get into the mindset of changing your ways. And so I began to start doing that. She gave me, yes, the potassium chart. I tried to follow it because every time it looked like anything that I wanted to eat, especially in the low potassium grid, it was like, who eats that? Who wants that? You know, so it was always that scenario where you make those decisions, but I had to make those hard choices. And so, you know, for 10 years I did that. You know, going back and forth, making the necessary adjustment, trying to, you know, find a mini win. So instead of me being you know, against my treatment plans and what was trying to be prescribed for me, I started being more proactive and more engaging. And so when I start seeing those mini wins, you know, like the one level might be down, like the potassium might be down this particular month, but the phosphorus might be a little bit up, elevated. I was like, okay, we're going to work on that. So I was more conscious then about my numbers and, you know, my levels, being really mindset. But as a miracle would say, finally, I got qualified for transplant. Here it is. Got transplanted in August of 2019. As a matter of fact, my newborn date is August 18th. 2019. I'm so excited about that because, you know, when you hear so often that you didn't qualify, you don't measure up, your GFR, your BMI, all of those things that's been taken into account, you know, being a transplant patient, when you see that you there, but you're looking at everybody else's success and you thinking, oh, Dallas is going to be the rest of my life. No, it's not. Here it is. Here I am. I'm transplanted. So now the mindset shift, because now I'm thinking I'm transplant. I can go back out there. I can definitely do what I want to do, eat what I want to eat. No, because that quickly got cut too. Because why? I found out that my medication, certain of my medications, was not only causing my blood serum levels in my labs to be high, but yet still, I'm thinking since I'm transplanted, I can go back to my guacamole. I can have my bananas. I can have my sweet potato fries. I can have all of the things that I enjoy. I love my colors. And so those foods that was high brought the richest color, and those was the ones that I wanted to eat. But no, they stopped that very quickly. So one of the things I learned, that transplant is not a cure, it's a treatment. So just like I had to focus on my treatment while I was in center, it's the same thing that I had to focus on my treatment being post-transplant recipient. So one of the things that was interesting, like I said, is my medication. And that one specific medication, which is, you know, we call it tracholamimus, but Prograf is easy to pronounce more so than the tracholamimus. And I found out that also, that medication can cause a higher level of potassium. So we began this regimen now of playing like a merry-go-round, up and down each month, trying to balance it out to try to make sure that I'm having the right content, intake of food consumption that will help, you know, keep it down, but then at the same time, watching my levels when I'm taking my transplant medication. And so, as you see here, you know, I had to start consuming a little bit more foods, but it became to the point that even then I have to begin to change what those foods was going to be, because it was causing those same issues that I was having in center as a transplant recipient. So, you know, the difference in that particular case, though, is now I was more aware, I was more in tune, because I began to do a little bit more, much more research into, you know, how I can help my kidney to stay, this transplanted kidney, to stay active, to stay healthy. And so a lot of things that what Carolyn was saying is definitely what I had to put into practice, put into play. You know, understanding portion control. That's when my nutritionist, you know, was helping me to develop an eating plan. Now, let me just tell you this, you know, I am a barbecue chick. I am a pizza chick. I love pizza. I love barbecue. I still love my avocados. But, you know, when I had to start thinking about, you know, do I want to maintain and I want to stay healthy, even though I love those foods, it's like I had to learn how to do it in moderation, that I could still get that same, you know, enjoyment, but yet still not to the point where it would cause me harm. So she helped me to design those plans, not taking away those foods, but balancing it in the right, proper way that I can have it and then try to help maintain and manage my potassium levels. So, you know, I went from, you know, 5.5 on my levels, with technically I think I only supposed to go as high as 5. So I started off in a progression of 5.2, 5.3, 5.4. The highest I've ever got was 5.5. But once we started implementing these plans, then I started coming down. I saw my mini win. I was at 4.8, 4.2. Just in my last lab, I was at 4.1. I was like, hey, you know, so I got excited about that. So it let me see that what I'm doing is working, you know, and it's working very well. So, you know, instead of, you know, trying to change it or, you know, go up or down, we finally found that balance. So when I said merry-go-round in the beginning, that's just something that I needed to do. But the one thing, though, in this particular case is because of the lupus and some of the other related issues, because I did have a stent of congestive heart failure complications in February 2016, and so I do have some issues with my heart. You know, and just a matter of fact, I was just at the cardiologist the other day, and he's like, there's some thickening building up inside of my inner wall that's causing it to like be extra stiff. So now we got to deal with that. And so I'm learning that what I eat is very, very important now, because everything has an effect. And so having an MRI showed that I have arthritis in my lower back, because I already know I had a Bose disc. So now the corona weight got to go. Because you know, when we say, you hear people talking about they had corona 15, no, I gained corona 40. So it was just that real. So now I'm being told that I have to, you know, really lose the weight, because the reducing, going into a weight loss program to get back to a certain balance is going to help all the way around. Because now not only was my focus was on the potassium, my focus is on the phosphorus, now it has to be on everything in one. So I'm no longer looking and concentrating on one particular level. I have to focus now and concentrate on everything. And so my journey with it is like a merry-go-round, but at the same time, the mini wins is helping me to see I can gain those controls. So, you know, that's some of the things that I'm doing right now to try to balance out my high potassium. So instead of me having on a regular basis my little wonderful guacamole dip from one of my very favorite restaurants that makes it the way I like it, I only visit it very short. So.
Thank you so much, Della. We appreciate you talking with us so candidly today.
Yeah.
Our final speaker today is Jane DeMeis. Jane advocates for better kidney education and for diagnosis of patients early in the disease process. When she retired after many years as a director of education and health advocate for large-sized people, she set out to become educated on nutrition and healthy living for patients with kidney disease who were not yet on dialysis. Jane is licensed as a public school teacher, a certified organizational development professional, a lean practitioner, and certified trauma professional. Jane remained at stage 3 chronic kidney disease for over 10 years. Being diagnosed in 2018 with stage 4 kidney disease was eye-opening, and she stepped up to become a volunteer with her local kidney organization. She also completed coursework to become a kidney coach, a peer mentor, and participates as an ambassador on Health Unlocked in their kidney forum. Jane feels very strongly that all patients deserve respect and the best treatment possible, no matter their size. The medical and health field, which she has been part of for over 11 years, is very discriminating against large-sized patients. She feels that many large-sized people do not participate in proper medical treatment in order to avoid the guilt and shame. Jane spent over 2 years suffering with ongoing joint pain. She was told repeatedly that it was due to her weight. All during that time, she was prescribed large doses of over-the-counter ibuprofen to manage her pain. When her hands began curling into fists, she was finally diagnosed with psoriatic arthritis, which causes high uric acid, and her kidneys filled with very large kidney stones that caused a lot of damage. If she had been diagnosed properly and earlier, she may not have the damage she has. Jane has been able to maintain her remaining kidney function with a renal diet using plant-based meals. Although not the reason, she has lost almost 40 pounds. She advocates for fresh homemade meals. She grows her own vegetables and herbs when she can and bakes her own breads from scratch. Jane feels strongly that patients should receive better education starting with stage 2 chronic kidney disease diagnosis. She feels that through better nutrition and lifestyle changes, many people can live healthier lives and slow the progression of kidney disease. Jane is an AAKP ambassador, and we are very excited to have her joining us today. Jane, I'll turn things over to you.
Well, thank you very much. I appreciate that. I do want to encourage that people of all sizes should be able to receive the health care that they need at the time that they need without having the guilt and the shame that's often associated with people of size. the issue that I had was the fact that I was an extremely active person for the majority of my life. I did not have diabetes. I later in life had some high blood pressure issues, but that was not anything chronic. And when I started to slow down and started to have the pain, they were so adamant about the fact that it was because of my size. And it really was detrimental, because that time the only thing they wanted to give me was ibuprofen, which we now know is extremely harmful for the kidney. So I managed as best as I could. I was teaching, I was trying to keep active with my tennis, and things just got to the point where I was really struggling, couldn't sleep because I was uncomfortable. But then the evidence when my hands started to curl was like, hey, you know what? My hands are not weight bearing. So there's actually something going on. And when they did finally diagnose me, my SED rates and my CRP rates were really off the charts, and they were like, oh, oops. So I was not really educated at that time. This is several years ago, on what you could do for renal diet. Their main focus, even when I did see the nephrologist, was again, lose weight, lose weight, lose weight. And I did try. I mean, you want to know anything about diets, ask a large person, because they've been on everything. I've been on Weight Watchers. I've been on all sorts of different types of things. I actually gained weight on Weight Watchers, which I, worked in the healthcare system and had a CDC dietitian, a diabetic dietitian, look at my food journals, and she's going, this does not make sense. You should be losing weight rapidly. And I'm like, gain 6. And so it was very confusing. So my GFR slowly crept down, my protein spilling increased, and eventually it got to the point where I said, I have to take control of this. One of the things I did do, which was one of the smartest things I've ever done in my life, was I retired, which got rid of a whole lot of stress. Stress is a huge factor on how you feel. I don't care what anybody says. Stress management is one of the first things anybody can do to help their health. I went and saw the nephrologist, who then turned me on to a renal dietitian. I, again, strongly encourage anybody who's in a CKD type of process that one of the first steps that you can do for yourself is see a certified renal dietitian. When I saw her, it cracked me up, because the first thing she said to me was, you're not eating enough. And I'm like, what? No one has ever said that to me. She goes, you're not. You're actually malnutrition. You're eating the wrong things in an attempt to lose weight. Your body is now hoarding anything that you eat, and you're not going to lose weight. So that was like, woohoo, I'm going to go party, which that really was not the answer to that solution at all. So she gave me some suggestions. She talked about high potassium. My potassium has been up to 5.7, 5.6, which is pretty high. And so having to change my diet was kind of almost natural, because I've been on diets for almost my whole life. So what she said made sense. She did one thing that is so important, is that she tailored it to my lifestyle, which is very important to being successful. Dieting is why it's such big business, is because people don't succeed long term. And I knew that this change would have to be forever. It was not just a diet, it was a lifestyle change. I love food. I love to bake. I love to cook. I love to grow it. I love to anything. I just love food. And my husband and I like to try new things. We like to go out. And so the lifestyle change was pretty easy for me, actually. I haven't eaten red meat since 40 years. I was just counting. It was like, holy crow. So red meat, losing that was not a big deal for me, but I am a chicken, ate chicken a lot. I was actually eating chicken every day. I was eating turkey. I was eating deli meat, even though I was buying the high cost stuff that had less processed foods in it. So there were little tweaks that I could make, but the one thing that was the biggest change in my lifestyle was I tracked my food. The dietitian gave me quotas of things that I could have. Protein level, carb level, fat level, and potassium, sodium. And at that time, phosphorus was not an issue, so I wasn't tracking that. And I actually logged in every single day and tracked what I ate. If it passed through my lips, it was in my diary. And that was really eye-opening, because you start to see, oh, wow, those little 4 cookies I snuck in, they count. And so all of a sudden, granted, I wasn't so totally focused on weight loss. What happened was, becoming aware of what I actually ate, I actually lost 38 pounds in less than 6 months without exercising extra more or doing anything really different. It was just a lifestyle change. Being somebody who loves to cook, I realized that this doesn't mean I can't cook anymore. I just need to learn more about what is good. So I started doing a lot of studying, a lot of reading, talked with other dietitians who were in the field, and found that there were some really wonderful things that you can do to enhance the foods that now I could eat. And being a gardener, one of the things I loved the most was actually being able to grow my own vegetables. And when you do that, the thing is that it's the purest that you can possibly have. I actually go out to my back porch into my lettuce garden. I grow red leaf and green leaf, which is actually lower in potassium than even romaine. And there's my salad. I grow basil and all different kinds of herbs. Adding herbs to vegetables, you could eat carrots 6 different ways just by changing the herbs that you add to them. So I roast, I grill, I saute. There are so many ways that you can enhance the things that you're doing. So I proceeded to really change those lifestyles. Bread, I love bread. I'm also a diabetic. My A1C was up to over 6 when this initial change happened, and I brought it down slowly. But I found that things that were high in glycemic levels were things that were processed. And although I love bread, it was like, oh, that's going to be out. Well, I found that if I made my own, all it is flour, a little bit of salt, a little bit of sugar, and a lot of work. And boom, you've got bread. And that bread does not raise my glycemic level as much. Not that I'm eating it every day, but that is a special treat when I really want to have some bread or something. We even learned how to make our own pasta, which you still have a higher glycemic level with that, but it's better for you. So COVID hit, and what happened was a lot of the products that I used regularly were getting very difficult to find. I have a low carb, low protein wrap that I use. That's a special wrap. I couldn't find it anywhere. Finding greens, because where I live, we don't have a growing season here. Very short growing season. The greens were very, very hard to find. Fresh vegetables became as bad as trying to find toilet paper. So it was a big challenge. And of course, the COVID weight, I confess, I had COVID weight put on. So around December, I had slipped to a GFR of 13. My protein was not good. My labs looked awful. Things were starting to fall apart again. And I was put through to the renal transplant to go through the evaluation, which I did go through. Unfortunately, my BMI is still too high. I'm not going to say too much about that, but I decided in January that it was time to take control again, and I went back to the same renal dietitian, and it was amazing how much has changed just in the 3 years on what now they know about what to eat and what not to eat. And so I decided, she was very plant-based. She herself is plant-based. My nephrologist is plant-based. What I was practicing before, she called a flexitarian, which I thought was kind of funny, because I did consume some chicken, very little fish, but I still was eating dairy, cream in my coffee, not creamer, not fake cream, real cream, cheese, love cheese, even still was eating butter, even though it was a half calorie butter. I still was consuming dairy products. So she challenged me to say, just try it, see what happens. So the results were, I am totally plant-based. It has been very easy change for me to do. I still track my food daily, but instead of doing it after the fact, I actually plan my food before I consume it, so that I know that if I'm eating this for lunch, that I can have more of something else, more potassium or more fat. I will tell you that my fat consumption is down to 28 grams per day. you want to challenge, that's one of them. That's pretty low. My protein is at 32%, which is really, really low. 32 grams, excuse me. It's very low. And she upped my carbs. She said, make your meals more carb friendly. And I was like, wait a minute, that's not the antithesis of what you've been saying for diabetes. Well, the end results are, and I did have a blood test a couple weeks ago, my GFR is back up to 15. My labs were terrific. My protein spilling dropped significantly. I was shocked by that. I've lost 23 pounds since January. Again, not doing extra exercise or anything else like that. It's winter here. We don't exercise. And I feel fantastic. So the key was really know what you're eating. Make sure that if you want to have something, that abstention is not necessarily poison. Just plan on it. If you want to have something that's going to be higher in potassium or higher in a level that you're restricting, then just plan to have something less. She even said, think about it in terms of the week. So one night, if you have a higher potassium or a higher intake on something, then the next day just balance it out with having less, so that you're not struggling to like forbid yourself from things, but learn to rate what you're eating, measure what you're eating, and still enjoy it, but just be careful of what you're doing. And it really becomes a lifestyle. I mean, I can look at a food now and know exactly what the food content is as far as how many grams of this are in it or on that. And I know what to shy away from. I will confess, my husband and I still do our popcorn with butter, but we limit it. And we're just very careful that we only do that one night a week and cut the fat level in it. And we cut it down. It's still popcorn though, but it is doable. It is controllable. And I really encourage, again, see a dietitian, base it on your lifestyle, and it is doable.
Jane, thank you so much. What a great presentation, and you touched on so many important things, especially not forbidding yourself from eating those things you love, but really limiting and planning in advance. So thank you so much for sharing with us today. I'd like to take a few questions that we've received from people during the webinar, and I will open it up to all of our speakers to respond to. So please jump in as you feel called to do. Our first question is from Jennifer. She asks, with plant-based foods, you only absorb about half of the phosphorus. Is there any clinical research that is showing that we absorb less potassium with plant-based foods?
Oh my goodness. I just talked about that. Yeah, Jennifer, certainly. It looks like you're only absorbing about like in between like 40 to 60%, if I'm remembering those numbers right, of the potassium in those plant-based foods. So I like to use beans as a good example, right? A half a cup of beans has about the same amount of, depending on the bean, but as the same amount of potassium as like 3 ounces of chicken. However, that chicken, you're going to absorb most of that potassium. You're not going to absorb most of that potassium. You're going to absorb about, let's just call it 50%, and we'll just hit it right in the middle. You're going to absorb about 50% of that potassium in those beans. So instead of just doing a half a cup of beans, you could potentially do 3/4 of a cup of beans. I recommend telling your diet, if you're on dialysis, telling your dietitian. And Jane, thank you so much for that plug on go and see a dietitian right out the gate, right? It's so important. But talk to your dietitian about that. Let her know what you're doing, and then maybe you can monitor the potassium levels while you're switching over to a little bit more of a plant forward style diet. And if you don't want to do that, that's also fine. But yeah, you don't absorb as much potassium in the plants. Sorry, I got a little bit distracted.
I kind of like to chime in on that because I kind of saved this for a reason. When my potassium for the last year was running around 5.2, one of the concerns was that it would creep back up. When I switched over in January to total plant-based, I was very concerned that my potassium would go up because all I was eating was plant-based. And my potassium actually went down to 5 in 3 months, which was very exciting. And I will tell you, I have brought back Brussels sprouts, which is a big no-no, which I absolutely love. And I'm actually eating beans, which I never was eating before for the last 3 years because of that.
Oh, thank you. Adam is asking if there are any foods to help lower potassium if his levels get too high. Anybody want to take that question?
I mean, I'll take it. No, once you absorb that potassium, it's in your body. You got to use that potassium. So if your potassium is elevated, a good way to absorb that would be, you could eat some like insulin stimulating foods like grains. That might help drive in that potassium. If you're on dialysis, go to dialysis. If you aren't on dialysis, you could drink some more water. If you're not holding on to fluid, that would help lower that potassium. Sometimes dehydration, you get high potassium levels. And also movement. The more you move, the more nutrients you use. So same thing with phosphorus. I mean, the more you move, you're going to lower those. But there's not a magic food that you can eat that's going to clean out that potassium.
All right, thank you, Carolyn. Lana is asking, how does low potassium affect the heart or other areas of the body? I know we talked a lot about high potassium, but how does low potassium affect this?
Actually, I'll take that one because the low potassium, and particularly when you start getting around 3.2, can cause the heart to also stop. So it can be just as dangerous as a high potassium. It's not as commonly seen in kidney patients because, again, as that kidney is weakening, that it's very unusual to. I have a few patients, honestly, who for some reason their kidneys get rid of more potassium weaker. Doesn't happen a lot. But yeah, that's an important consideration, is that you don't want to go too high. I call that the Goldilocks. You want that 3.5 to 5, but you don't want to get it down too low because it's almost just as bad. You get a lot of the same issues that you do get with the high. And the other side in terms of food, the one thing I kind of alluded to, when I was speaking is, if you think your potassium is going up, I mean, really get it checked. I am sometimes shocked. I'll have the patient come in that's been outside mowing, they got dehydrated, who, grabs a glass of orange juice, again, that bioavailability issue, and they come in the next day and I'm seeing a 6 potassium. And then I have to intervene medically to pull that out with it. So, I can't encourage enough to, to have people get checked. I leave a standing order for the patients for a reason, because there's nothing wrong with getting it checked if you think it's up or you think you're getting these symptoms with it, because you're thinking about it. It's like, wait a minute, I think I'm symptomatic. So.
Thank you. Now, as far as getting your labs checked specifically for potassium, is that something you can just walk into your doctor's office and request that, or how often does your dialysis unit track that? Anything you can share about that, I think, would be helpful.
Well, I'll kind of jump on this way. In dialysis, typically that's looked at every time they're drawing blood, because potassium goes up so easily and so quickly, especially when you are in kidney failure. Otherwise, it kind of depends if you're not at dialysis level, whether you're transplant, whether you're CKD stage 1 through even 5, where you're not yet on dialysis. It kind of depends on what your body's doing. This idea of individualization is absolutely critical. Some people, I never see a high potassium on. I have others that do it a lot, that do it a lot of times. And that's where you have to kind of start making decisions. If you're seeing a lot of these spikes about, oh, geez, is there something we can do to modify it and control this? Talking to the dietitians, absolutely, so important. It's so awesome to hear Jane and Della talk about their experiences and what they were able to do. I think it's a testament to, yes, you can do it, but you got to put in the time and you got to pay attention. And it's hard. I mean, genuinely, Carolyn would be sitting there shaking her head on this one going, to do this dietary wise is difficult. It's doable. But sometimes things don't always play fair. That's the thing I'll say in kidney disease is sometimes we want to use certain meds or we want to do certain things. I just have a kidney that's not going to cooperate with it, and we have to manipulate or try certain things. It's hard.
And if I can share, Aaron, you know, what Dr. Dr. Smith was just saying, for me, when I was in center, because was really, really so important that they keep track of it, like when we would have our monthly lab. So it would be at the beginning. So 2 weeks later, they would just specifically only check either my potassium or my phosphorus, whichever one that was showing the high levels. And then since being outside of the facility, outside of dialysis now as a transplant patients, what they tend to do for me, because they are monitoring it, either every other week they will check it, because what they want to do is try to make sure that the measures is in control. And then once we get it to the right number, then it's like a couple months from that's when they'll come back and take a look at it. Once we get it right there, because it over time it increases. Not like if month of January, maybe January 15th, it was high. You know, once they take a retake, probably I won't have to see them again until March or so, because we've now developed whatever the plan. So it's really one of those doctor's led type of thing. But I just know it took my part, me to be engaging. So I had to be conscientious of what food intake that I was doing as well, because I didn't want to try taking the potassium binders. That was something I made the decision I did not want to do. On top of everything else that I'm already taking, that was one thing I did not want to do. So I had to begin to make the adjustment, to do something naturally more than medically.
Thank you, Della. And when we have one final question from Renee, she asks if she should really never eat avocado. Carolyn, do you want to take this one?
I mean, it's all about moderation and individualization, right? So, I mean, let's say you're somebody that rolls with the potassium around like a 4.8 to 5.2. Well, probably not. And if you do, gosh, it's like a sliver. If you're somebody that is over 5.2, then you really shouldn't have any avocados at all. They're also not an insulin stimulating food, so it's not going to drive that potassium into the cell. But okay, so now your potassium's a 4.8 or under. Yeah, I mean, like you could have a couple of slices of potassium of avocado on your sandwich, or you could have an egg sandwich with some avocado. Maybe not avocado toast, because that's probably like a half of an avocado. It's all about the size and what your numbers are.
Great, thank you. Well, thank you all so much for your wonderful presentations, for answering these questions. If anyone has a question, please send it to info@aakp.org, and we can work with today's speakers to get those questions answered. We have a couple of closing slides that we'd like to leave you with today. If you are not already a member of AAKP, we encourage you to join us. We offer free membership for patients and family members, and you can join online or by phone. And also, if you want to receive all of the benefits of membership, please include your email address when you sign up. You can select to receive any of our 5 different electronic newsletters and subscribe to our printed magazine, AAKP Renal Life. We also encourage you to follow us on our blog and social media for all of the latest news and announcements. AAKP is dedicated to helping patients understand their condition and take control of their health care. We offer many resources to help patients adjust to diet restrictions while still enjoying eating. Our nutrition counter, which is also available in Spanish, has a long list of foods with the amount of sodium, potassium, phosphorus, protein, and calories that you can easily carry with you to the grocery store or when you go out to eat. We have a new pocket guide for managing high potassium, which aims to help patients have more effective dialogue with their healthcare teams. In our delicious recipe card series, which Carolyn kindly showed some screenshots of, they include our complete nutrient analysis, easy to follow instructions, and pretty photos of food. AAKP is proud to offer a variety of resources for both patients and caregivers, including information on coping, living, and thriving with kidney disease, understanding gout in your kidneys, and a whole slew of other information. You can visit our website at aakp.org, click on the AAKP store button at the top of the homepage. You can download educational brochures, or you can order them online or by phone. Also on our website, under the Center for Patient Research and Education tab, you will find a link to related health conditions. On this page, you can find information on a number of conditions that can affect kidney patients, including anemia, diabetes, heart disease, and potassium. I'd like to highlight a few of our Are You OK campaign materials available on www.ruok.org, including an infographic and fact sheet, both available in English and Spanish, and our potassium check quiz. AAKP holds a number of events throughout the year, and these events are live streamed and recorded. Please register for free for any and all of our 2021 virtual events, including our Global Summit on Kidney Innovations, hosted in partnership with George Washington University, our annual Policy Summit, and our annual National Patient Meeting. You can also catch past sessions on demand on our YouTube channel. We'd again like to thank today's speakers, Dr. Cindy Smith, Carolyn Feibig, Della and Jane DeMeis, as well as Vifor Pharma for providing an educational donation for this Healthline webinar. If you have any additional questions about what you heard today, please send them to info@aakp.org. Thank you again for joining us. Be informed and stay safe. Thank you.